Okay, so you're having a baby. Good news, you have insurance. Good news, your plan includes maternity coverage. Good news, you've looked up your out-of-pocket maximum and you know the worst-case number. You've done everything right. 3 weeks after you bring your baby home, the bills start arriving. Not one bill, 3, then a 4th, then a letter from a collections agency about an anesthesiologist you don't remember meeting. The United States spends more money per birth than any other country on Earth. The average hospital delivery costs $32,000 before insurance adjustments. It has the highest maternal mortality rate of any high-income nation. And the average new parent, insured, prepared, doing everything correctly, still spends nearly $3,000 out of pocket on delivery alone, before the bills they didn't know were coming. By the end of this video, you will understand exactly why. You assumed maternity coverage meant the birth was covered. It means the birth is partially covered by the negotiated rates of every provider involved. And here is what almost nobody tells you before the delivery date. The providers involved in a single hospital birth are almost never all employed by the same entity. The hospital is one business. Your OB is often a separate business. The anesthesiologist who administers your epidural is frequently a third business, contracted to the hospital but not employed by it, sometimes not even in network with your insurer. The neonatologist who checks your baby in the delivery room may be a fourth. You chose one hospital, the hospital chose everyone else, and their contract status with your insurance company is something you will discover on the bill. By the end of this video, you will know exactly what bills a standard hospital birth generates and why they come from different places. You will know the one question to ask your hospital before your due date that changes what you owe on the anesthesia bill. You will know what NICU exposure actually means financially and why 1 in 10 births triggers it. And you will know the income math that nobody puts in the birth plan. Let's start with the 3 bills. Bill 1, the hospital facility fee. This covers the room, the nursing staff, the labor and delivery suite, the equipment, the IV lines, the monitoring, everything the hospital itself provides. For a vaginal delivery, the facility fee averages between $10,000 and $20,000 at chargemaster rates before insurance negotiation. For a cesarean section, that number rises to $20,000 to $35,000. After your insurer's negotiated discount, you'll pay your deductible first, then co-insurance on the remainder. According to the Healthcare Cost Institute, the average out-of-pocket cost for a vaginal delivery with employer-sponsored insurance is $2,854. Bill 2, the professional fee. This is your OB's charge, separate from the hospital, billed under a separate provider number, processed as a separate insurance claim. If your OB is in-network, this is usually manageable. If your OB is in-network but the hospital your OB delivers at has changed its staffing contracts since you chose your doctor, you may find a surprise. Bill 3, the anesthesia fee. This is the bill Maya did not expect. Maya was 29 years old, a marketing coordinator in Austin. She had checked her hospital's network status before choosing where to deliver. She had confirmed her OB was in-network. She had looked up her out-of-pocket maximum. What she had not done, what almost no one does, was call the hospital and ask which anesthesiology group held the contract for the labor and delivery floor, and whether that group was in-network with her insurer. The anesthesiologist who administered her epidural was not employed by the hospital. He was contracted through a separate group. That group was out of network. The bill arrived 6 weeks after delivery, $2,200, before the No Surprises Act took effect in 2022. This was entirely legal and entirely common. The No Surprises Act now protects patients from surprise out-of-network billing in emergency situations. Scheduled deliveries occupy a legal gray zone that continues to generate disputes. Maya's epidural was not administered in an emergency. It was administered during a planned labor. She is still appealing the bill. Now here is the risk almost no birth plan addresses. Roughly 1 in 10 newborns in the United States require some level of NICU care. That is the neonatal intensive care unit, the specialized ward for babies who need monitoring or medical intervention after birth. The reasons range from premature birth to mild jaundice to low birth weight to respiratory difficulty. Many NICU admissions are brief, 1 night, 2 nights, for mild jaundice under a phototherapy lamp. The cost of a NICU admission in the United States runs between $3,000 and $5,000 per day before insurance negotiation. A 2-night NICU stay for mild jaundice, the most common reason for newborn NICU admission, generates a bill between $6,000 and $10,000. Maya's daughter spent 1 night in the NICU. mild jaundice, resolved completely by morning. The bill was $5,100. After insurance, Maya owed $1,800. On top of the delivery costs she had already budgeted. On top of the anesthesia bill she was still disputing. You are not paying for the birth of your child. You are paying for the particular building your child happened to be born in, and the particular contractual relationships that building had with the people who worked inside it that day. Think of it like booking a hotel room, assuming everything inside is included, and then receiving separate invoices from the chef, the electrician, and the person who cleaned your room, each one operating under a different contract with a different billing code, processed through a different insurance pathway. You chose the hotel. The hotel chose everyone else, and their rate structure was never part of your booking. So now you understand the bills. The facility, the OB, the anesthesiologist, the NICU, each one a separate business, each one capable of generating a separate surprise. But there is a layer of this that goes beyond Maya's individual situation. Because the thing that makes the American birth experience economically unique isn't just the billing structure. It is the entire policy context that sits around it. And when you compare that context to every other wealthy country on Earth, the numbers stop making sense in a way that should make every American uncomfortable. The United States spends more on childbirth per birth than any other high-income country in the world. According to the Peterson KFF Health System Tracker, the average total cost of a hospital birth in the U.S. is approximately $32,000, compared to $5,000 in Australia, $4,000 in Germany, and under $2,000 in the Netherlands. Same biological event, same outcome, 5 to 16 times the cost. You would assume that cost difference produces better outcomes. The Commonwealth Fund's most recent International Health Policy Survey ranks the United States last among 11 wealthy nations on maternal mortality. Last, the U.S. maternal mortality rate is approximately 23 deaths per 100,000 live births, more than 3 times the rate in the United Kingdom, and more than 5 times the rate in Australia. The country that spends the most on having a baby loses the most mothers doing it. That is not a healthcare quality problem. It is a structural problem, and it shows up most clearly in what happens after the birth. Every other high-income country in the world, every single one, mandates some form of paid parental leave at the federal level. Canada, 35 weeks of paid leave. Germany, up to 14 months. Japan, up to 1 year. The United Kingdom, 39 weeks of statutory paid maternity leave. The United States, 0 weeks of federally mandated paid parental leave. The Family and Medical Leave Act entitles eligible workers to 12 weeks of unpaid, job-protected leave. Unpaid. Maya took 6 weeks of leave after delivering. Her employer offered no paid parental leave. 6 weeks of her salary, $9,600, disappeared from her household at the exact moment her household expenses increased. The delivery cost $2,154 out of pocket. The anesthesiologist cost $2,200. The NICU night cost $800. The unpaid leave cost $9,600. Total cost of a planned, healthy, uncomplicated pregnancy, just over $16,000. She had budgeted $3,000. The budget was based on the insurance cost. The insurance cost was the smallest part of the bill. Here's what changes once you know this. Ideally before your due date, not after. First, before you choose a hospital, call the hospital's labor and delivery department and ask specifically, which anesthesiology group covers your labor and delivery floor, and are they in network with my insurance plan? If the answer is no, or if they cannot confirm, ask whether you can pre-authorize an in-network anesthesiologist to be present or on call for your delivery. Some hospitals will accommodate this request. Some won't. Knowing in advance gives you time to either switch facilities or prepare for the out-of-pocket cost before the bill arrives while you're caring for a newborn. Second, ask your OB at your next appointment. Do you have admitting privileges at more than one hospital? And which of those hospitals has full in-network coverage for all providers on the labor and delivery floor? This is a question OBs are accustomed to and rarely get asked. Third, if your employer offers any form of paid leave benefit through a short-term disability policy, a state program, or a company policy, start that paperwork now, not the week before your due date. Several states, including California, New York, New Jersey, Washington, and Massachusetts, have state-level paid family leave programs that supplement or replace unpaid federal FMLA. If you live in one of those states and are not enrolled, check your eligibility today. The March of Dimes has a free state-by-state paid leave guide linked in the description. Fourth, Budget for the NICU possibility. A NICU stay affects 1 in 10 births. You do not need to fear it. You need to account for the financial possibility of it the same way you account for other unlikely but real events. If you have an HSA, the NICU costs are qualified medical expenses. Fund it before the birth if you can. You planned for the birth. You budgeted for the copay. Nobody handed you the bill for the anesthesiologist who walked in uninvited, the NICU night nobody predicted, or the 6 weeks of income that disappeared while the country offered you nothing. In every other wealthy nation, at least one of those 3 costs either doesn't exist or is covered. The baby arrived healthy. The system she was born into was not designed with her parents in mind, and the gap between what you expected to pay and what you actually owed, that gap is not a billing error. It is a policy choice, made by a country that spends more on this moment than any other, and has decided that what happens after it is your problem. If you are pregnant or planning a pregnancy right now, do 3 things before your next prenatal appointment. Call your delivery hospital and ask which anesthesiology group covers labor and delivery and whether they are in-network. Ask your OB if they have privileges at multiple hospitals and which has the cleanest network coverage. And check your state's paid family leave program through the March of Dimes link in the description. These are 5-minute calls that can save you thousands. If you know someone who is pregnant and hasn't done this research yet, send them this video before their due date, not after. The time to learn this is before you're reading it on a bill at 3 a.m. with a newborn in your arms. Drop in the comments. If you've had a baby in the US, what was the bill you didn't expect? The anesthesiologist? The NICU? The unpaid leave? Tell me exactly what happened. I read every comment. Your story is the next parent's warning. Next week on Body of Debt, we begin the chronic disease series. 38 million Americans have type 2 diabetes. Most were on track for it for 10 years before anyone told them. And the financial cost of that decade, before the diagnosis, not after, is something nobody in medicine ever shows you. Subscribe so you're there when we do.